Good. Well, I would like to welcome everyone to this SDSMA Center presentation on liability issues with physician extenders. This presentation is brought to you by the SDSMA in partnership with MMIC. Please note all lines have been left open so you can ask questions of our presenter as we go. However, if we do pick up a lot of background noise, we will place lines on mute to make it easier for everyone to hear. If they are placed on mute, we will stop periodically throughout the presentation so you may ask questions. We'll also have a Q&A period at the end of this presentation. Today, we like to make these programs as informative for you as possible, so we encourage you to participate in these questions if you have them. That's what we're here for. So at this time, I'm going to go ahead and introduce Robert Thompson with MMIC. Robert is the Director of Education at MMIC, and he has a diversified background in law, medicine, medical, professional liability insurance, and healthcare risk management. Mr. specializes in patient safety, risk management, and health communication. And Robert, I'm going to turn it over to you and have you lead us through this presentation tonight.
Thank you for the opportunity again to be with you all. And, you know, it's an appropriate time for this topic. South Dakota and the South Dakota Medical Association is on the leading edge. Some of these topics that we've done over the past 18 months, this one more so than any, you know, this was picked a significant amount of time ago to look at the issues, particularly the liability issues that we're seeing out there with physician assistants and nurse practitioners, particularly in light of the increased use of these physician extenders across the entire country and even more so in rural areas. So the topic was picked a significant amount of time ago. In recent months, I've seen this topic popping all over the management and patient safety and professional liability screen. So excited to spend a few minutes with you here and discuss what we're seeing from a professional liability standpoint, and hopefully provide you all with some focus of where the problems are coming from. The potential issues are, where the contributing factors and places of loss, the local loss, and the reasons for those losses dealing with physician extenders are coming from. So we'll move forward into this. The topics for today, we're going to talk for just a couple of minutes about TRICO. Is a group that we affiliated with in a significant data sharing project. I've mentioned this in a couple of the other programs that we've done. A lot of the information that comes, particularly the statistical information, comes from the TRICO BS database, closed claim database on medical malpractice claims. That's a statistical significance in the number of claims that they are able to look into dealing with nurse practitioners and physicians assistants. So discuss that system briefly and how this information comes about, and a couple of minutes about risk management and malpractice. Then we'll move into the claims environment, but focusing particularly on the claim information from the TRICO CS case related to nurse practitioners and physicians assistants. We'll do a brief data overview of physician extenders, and then talk about the liability issues that we see, and then risk management suggestions, some things that physicians particularly could keep in mind as we see this extended practice in the use of PE. Today is a talk for just a brief slide about the upside of physician extenders. We're seeing a number of significant advantages out there in all aspects of care. The care setting, inpatient setting, ED setting, where we're able to provide better care because of the use of physician extenders. As so many of these situations, with these come increased risks, and hopefully some of this information will allow us to off some of those risks before we get that far. That's briefly the liability risk and the common errors that lead to liability claims. And then suggestions that we can from a risk management and patient safety standpoint to hopefully help you minimize that risk that you see out there. That I use in almost all of my programs, and I want to draw attention to the fifth bullet point here, malpractice plus, or the X factor. That is the focus that we have seen in recent years in medical malpractice cases, particularly come from plaintiffs' attorneys on the service side of what we do. A little bit of a look away from clinical aspects of more focus on the service side and service lapses. And you'll see tonight, as we dig through the liability issues with these, we'll go back again and again to diagnosis, delay in diagnosis, failure to diagnose, those types of issues, because they're so prominent in the case studies and the closed case acts. Practice standpoint, we'll talk about physician extent, and for that matter, even in the physician world, the DO and MD world. Big issues out there right now, but what we see is that it is service lapse, error, follow-up systems error, those issues from. I'd like to say, as I mentioned, that we were going to look at the CBS, the CRICO database. The banking system is what it is. And a system that started at CRICO, which is the insuring arm of the Harvard system up in Boston some 30-odd years ago. They looked at practice from a different standpoint. They didn't look just at the financial aspects of those claims. They looked at the clinical aspect of those claims, the legal aspects, the contributing factors to medical malpractice claims, and collected significant amounts of data on those other than financial areas. So over the years, they have built a significant database that allows us now, in affiliation with them, to slice and take a good in-depth look at the contributing factors, the reasons behind these issues that led to medical malpractice claims. So at this point in time, you can see everything in red there is, and actually grown since then, is represented by groups that have an affiliation CRICO and with CBS. So we, as NMI, see that vast swath of the Midwest, the core states coming down through the middle of the country, that for a long time CRICO didn't have any representation, any input from our area of the country. So at this point in time, we're seeing a database that represents 30% of all of the cases that have been reported to the National Practitioner Data Bank. So we're talking about a significant number of malpractice claims that really allow us to get the depth and breadth that we need, try to put together some preventative programs and services to work toward alleviate some of these issues we see in the malpractice claims. So if you're here, and these numbers have grown significantly since this slide even, in excess of 300,000 medical malpractice cases coming from hospitals and healthcare entities, in excess of 400 providers, and in excess of 165,500 physicians represented across the states. Between 8,000 and 10,000 new cases to the database per year. You can see this does include 23 academic medical centers. Again, just to kind of show the statistical significance that we see out there. The CBS participants, the members of the original CRICO system, you can see Mass General, Beth Israel, Deaconess, that are prominent in the healthcare world. Physician insurers, the Doctors Company, Medical Protective, up there, MMIC. Other hospitals and healthcare systems across the country, Stanford University, University of California, UCLA, Florida Shands. So this is where the data goes into this database being collected from. The system that we get to do the clinical coding to get these claims into the database is intricate, it's very in-depth, it's very detailed, and it's very closely monitored by the folks in Boston to make sure that the data in that University of Florida case is being coded the exact same way in Minneapolis, Minnesota, or from a claim coming out of Sioux Falls, South Dakota. So they're sure that we're comparing apples to apples. So this technology was established in 1990. If you look, it says that there's proven success in the CRICO.
Knock it off!
What we see is that the physicians who are paying malpractice premiums that are practicing in CRICO had significant decreases in claim rates and significant decreases in the cost of their malpractice premiums. And I think the driver in getting other participants from across the country to how they were doing what they're doing. So this takes 650 proprietary codes that are captured from clinical and legal details, and then puts into technology where we can slice and dice and dig into these claims to figure it out. So this is what has allowed us to look into the issues even a smaller cross-section for our program tonight, looking at what we see with physician extenders. So just to give you an idea, the primary category here, there was an issue with, this is a situation of a malpractice claim, there was an clinical judgment, and then the step back from that looks at assessment issues. So there's one of seven mid-level categories. This one is patient assessment issues. And see the detail that it looks down into, so that we're not just guessing as to what happened. We're able to put our finger on directly what happened, so that we can do what we need to do to try to prevent these things from happening again in the future. Let's talk for just a couple of seconds about what we're seeing as far as the rationale for the utilization of advanced practice providers or physicians. A significant increase the number of both nurse practitioners and physicians assistants, and as you'll see in just a couple of seconds, potential for both of these professions is staggering. So a number of reasons. With the Affordable Care Act, with the to provide access to care to more rural areas, with the for us to provide better care to patients in all care settings. There's a way for us to leverage the skills of physician and the skills of these advanced practitioners to provide the best care possible for our patients while maintain and contain the cost out there. So this allows the patients to focus on higher acuity problems. It allows them to focus their attention when needs are best served. And as it does improve access to health care, especially in the rural areas, we see a good bit of use of nurse practitioners and physician assistants across both of the Dakotas and Alaska. I think that if you look at the of those areas being served by a physician, I think what happened. We are seeing the use of nurse practitioners and physicians assistants in areas that would be underserved, or not served at all, if it weren't for that capability being there. Improve patient satisfaction and education. The fact of the matter is that because of these physician extenders, patients are able to spend more time with their care providers, to be educated directly by their care providers, as opposed to what we have so prominently in the past 5 or 6 years, the use of WebMD as the main source of medical clinical information. And so is that when patients have the opportunity to face-to-face and to spend time with those that are providing care, not only does their satisfaction go through the roof, but also see that they're compliant, that their willingness to participate in their own health care increase significantly. And when that happens, there's a direct relation to quality of the outcomes that patients experience. If you've got the patient on board and the healthcare providers on board, and we see better clinical outcomes. So it's a satisfaction tool, it's an education tool, it's it's a for us to be able to increase the quality of the healthcare that's delivered across the country. Help to lower overhead and contain healthcare costs. Particularly when we're talking about those lower acuity problems, let's put providers that with those lower acuity problems in an area where they can do that, which allows the physicians, the MDs, and the DOs to focus on those problems that they're better prepared and better able to handle. And then hours coverage. In our physician base gets thinner and thinner over the past 10 or 12 years, where doctors have had a significant decrease in their quality of life because of time that they were having to put in to the job. I think that when done correctly, the use of extenders in across the spectrum can allow some of that after-hours coverage that allows for quality of life for the physician base. Provides coverage in situations where if it weren't for these physician extenders, we have coverage. So let's talk about what we see from physician assistants and some of the facts around physician assistants. In 2012, the census showed that there were 86,500 PAs across the country, and what anticipation is that we'll see an increase about an 8-year period of about 25%, going from 8,500 to 8,300 assistants in 2020. It's projected to be the second fastest growing healthcare profession in the next decade, and it wouldn't surprise me if we were to see these numbers surpassed. Again, I think once we figure out exactly how to leverage the capabilities of vendors properly and in a manner that is best for the patients and for healthcare providers, I think that we'll see this growth continue. You hear some of the evaluations as to dire circumstances on the physician shortages that we see out there and the nursing shortages that we see out there. I think those gaps are going to have to be filled, and maybe through the use of physician assistants and advanced practice nurses that we're able to cover some of those gaps in the upcoming years. 50 states give physician assistants prescribing privileges. 40% of PAs perform invasive procedures. So this is about fairly significant clinical capabilities, fairly significant skills here. And when we look at that, we know that there are risks associated with it. We expect we will see significant increases in liability issues as we see the growth, not just because of this projected growth, but because of the responsibilities and because of the type of practice that physicians, assistants, and nurse practitioners are being involved in. In the RICO webinar that I attended, they had done a survey looking at academic medical centers, commercial insurers, and community risk retention groups, and told them to go on what they were seeing from these physician extenders as far as their involvement in medical professional liability cases. And 75% of the respondents in that survey said that they were seeing increased involvement. So if we're seeing it already in 2015, as these numbers grow and as the responsibilities grow, we can expect that we will continue to see that. That were identified in that particular study that they were seeing related to cases, communication of the respondents. 100% of the respondents said that they were seeing issues related to communication, that being patient communication and communication issues, and seeing that being in this particular instance between the physician's assistant and the physician supervising. Communication we know is a big deal. 63% cited supervision as issue. 38% said scope of practice of the extenders, and 50% cited that they were seeing issues related to teamwork. Again, these issues directly to med-mal cases involving physicians, assistants, and nurse practitioners. Just to get down by specialty, about 43% of all physician assistants operate in the primary care world, 24.8% in family medicine. But we spread out pretty broadly, particularly with the PAs. 10% of PAs are operating in the emergency medicine realm. So this is a little more spread out than we see in the nurse practitioners that I'll show you here in just a couple of seconds. So I'll get too in depth into the regulations. Again, I'm focusing more today on the liability, the professional liability that we see. And these rules and regulations are run state by state. They're very intricate. They're regulated in most instances. And so there are situations where you have to talk to your own legal counsel. You have to talk among yourselves to make sure that from a regulation standpoint that you're doing what you need to be doing. So the assistants are regulated by the state medical boards throughout the country, and make sure that the supervising physicians are keeping current with the laws in the state where they practice. So they can't practice independently. Make sure that those collaborative practice agreements or delegation of services agreements that are between a collaborative physician and a physician's assistant are being followed. And these are things that you should take into your legal counsel, make sure that they're abiding by the laws of South Dakota. So let's a couple of seconds here about advanced practice nurse facts. There are currently 189,000 nurse practitioners practicing in the United States, and there are 14,000 new nurse practitioners added in 2011 through 2012, and there are 34% increase by 2020. So just explosion of growth in nurse practitioners. So 87.2 are in the primary care site, and 97% of nurse practitioners prescribe meds with an average of about 19, depending on which study you do, 19 or 20 prescriptions a day. So operate pretty in depth clinically. With that autonomous nature and the in-depth nature of what they're doing, there are risks that we see associated with that. So over 44% of nurse practitioners hold hospital privileges, practicing that inpatient setting. 8% primary defendant in a medical malpractice claim. So this is one of those situations where we are seeing advanced practice nurses being named the defendant, and they autonomously in situations that this isn't something that's a I mentioned. The advanced practice nurses looking at their specialty, almost 50% of them are in the family practice realm. We see, particularly in the rural areas where an entire area will be served by nurse practitioners. So just to get an idea of where they're operating, where potential for these areas of loss are. Nursing boards and nursing regulations, again, making sure the laws in the state where you practice, state of South Dakota, and they can practice independently in most states, and they don't require physician supervision in most states. Sometimes we have a voluntary nurse practitioners collaborative practice agreement with physicians. Just the ability to serve as a sounding board. You've got that reference and that ability for a nurse practitioner to separate clinical issues with patients. So doing diagnosing or tests, referring patients in out to specialists. A specific limited scope of practice. So just as in a registered nurse, there is a scope of practice that is deleted in most instances. They carry their own liability What we see is that most states have professional liability insurance that is provided for nurse practitioners through the state nursing board, and the in years past have been very, very reasonable. And how much that's going to hold true with growth of advanced practice nurses, we'll keep our finger on the pulse of that and see what happens as time goes on. Is that we have seen instances where even there isn't a collaborative agreement to be named in a malpractice claim, if there's a documented consultation or collaboration that goes on, and even when there isn't a collaborative practice agreement or written agreement, there's a significant amount of collaboration that goes on between nurse practitioners and physicians. So we've seen those scenarios where a doc is named in a malpractice case because of a consultation or some sort of collaboration that was going on. So the data overview of this banking system claim data from CRICO looked at was the years of 2009 through 2013 involving physician extenders. What they came up with were 232 cases that directly involved a nurse practitioner or physician's assistant. 10% of those involved the nurse practitioner and 55% involved the assistant. This was a staggering number. I didn't expect it to be high, but 80% of those 232 cases also have a physician dependent name. So that's just how much of a risk we see physicians pick up in these scenarios. Of these that were evaluated, 40% of them had a diagnosis-related allegation. I don't know that this is too far askew from what we would see in general medicine coming physicians. We know that we have issues in this country related to failure to diagnose, delay in diagnose, some sort of related issues. I don't know that it would be high at 40%, but what we'll look at is some of the issues related to diagnosis error that are particular or are more commonplace when we're talking about nurse practitioners and physician assistant. 3% of these cases resulted in high severity injuries. 27% of these cases actually resulted in a patient death. So what is that most cases involving physician extenders hinge on coordination of care issues, physician's assistant working with a collaborative physician, team communication issues. We programmed earlier for the State Medical Association that was on patient and team communication. When we're talking about the need for collaboration and for close as possible, or for recognizing when a physician extender should willingly pass and forward a patient on to a physician. This communication issues is where we see a lot of these issues coming from. So the physician extender cases by location and over time, from 2009 to 2013, the case involving physician extenders, 44% of those cases were in the ambulatory setting, and that percentage was holding flat. It had gone up a little bit over year and then down and fluctuated a little bit, but about still maintaining about 44% across the board. From 2009 to 2013, 35% of those cases were in the inpatient setting and increasing, but not staggeringly, where I think we're seeing more particularly nurse practitioners in the inpatient setting, and then also physician assistants working in some of the specialty and subspecialty part of medicine, operating in the room and in the inpatient setting. So 10 of these cases were in the emergency department, and that nearly doubled. In 2009, about 50% of these cases were to 30% for an average of 20% of these cases, about 20% of these cases in over time from 2009 to 2013. So we know that we're heading up with those cases and pretty significantly. These extender med mal claims in the ambulatory setting, nurse practitioners accounted for 50% of those claims, and physician assistants accounted for 40%. The times that we see, no surprise, again, as I mentioned at the beginning, and as we touch on as we come through, most are diagnosis related. 48% of the cases, ambulatory setting, when we're talking about physician extenders, are diagnosis related allegations. Treatment came second at about 23% of those cases. So as we back down from that top allegation, look at the contributing factors that we see in the ambulatory setting. Failure to order diagnostic test was present in 25% of the cases. Failure to establish a differential diagnosis was present in 2% of the cases. Obtaining a referral or a consult, present in 10% of the cases. And then related to communication among providers, reference to the patient's condition, present in 12% of the cases. So the face in these particular situations is, especially if there's some sort of collaboration between a extender and a physician, that if we case where there was a failure to order a diagnostic test, the natural question that we see is, well, would a physician have ordered it? If this was an MD that was looking at this, would this doctor have ordered the CAT scan or fill in the blank to establish a differential diagnosis? Well, this was in the hands of a physician, an experienced physician. Would he have approached the diagnostic processing differently so that there would have been the establishment of differential diagnosis? So from a standpoint, I think that we find ourselves in a difficult situation when the Monday morning quarterbacking looks at a scenario and then compares it to what it would have been if a physician were looking at those particular cases. Cases are driven by diagnostic process error. If you look in those cases, both for nurse practitioners and physician assistants, patient assessment and evaluations of symptoms and issues was present in 40% of the nurse practitioner cases and 3% of assistant cases. Processing, those issues were present in 48% of nurse practitioner cases and in 64% of physician cases. And then during a diagnostic or some sort of lab test, those issues were present in 48% of nurse practitioner cases and 36% of assistant cases. So the process of these assessment process, the ordering of the correct types of labs or diagnostic tests, thinking about those being present in the 40s, high 40s, and instance here into the 60% of these cases. Where our issues are, we know that we've got to start discussing the fact that we know where these problems are coming from. MMIC, our Chief Medical Officer, Dr. Lori Drill-Mellon, has been working with CRICO and with CS on developing programs related to delay in diagnosis, misdiagnosis, diagnostic error issues. That's a direct response to first 3 years of our company's malpractice. We've got 3 full years of malpractice claims coded, and what has popped up over and over and over again are diagnosis issues. So these numbers are pretty staggering. Like I said, in the 40s, it's surprised that there are issues related to diagnostic process. Ambulatory to the inpatient setting. The inpatient setting cases are evenly distributed between nurse practitioners and physician assistants. Top patient, not surprisingly, is surgical treatment in 45 cases, medical treatment in 15% of the cases, and the diagnosis-related issues in 13% of the cases. And look back down here at the contributing factors, that number one popping up again, the failure or delay in ordering diagnostic tests, 15% cases, then failure or delay in obtaining a referral or a consult comes up in 12% of the cases. So, or inadequate assessment, failure to know the patient's condition, 11%, and then again coming up, communicating among providers in patient condition, came another 11%. So the good thing is that we've got processes and we've educational programs put together that address some of these issues, particularly the contributing factors. We've been working for the last 2.5 years on patient communication and communication among the healthcare team to kind of knock down some of these contributing factors that we see out there. So from the inpatient setting to the emergency department setting, 90% of all ED claims involve PA, and not a big surprise to us. We see that a lot of our rural departments on a fairly routine basis, and then popping up that top allegation. 70% of the cases in the ED setting are allegations related to diagnosis, failure, diagnosis, delay in diagnosis. Medical treatment coming in second at 26%. So this is strong different dance here. Contributing factors: failure, delay in order diagnostic test, probably 26%. Failure to establish that differential diagnosis, 26% of the cases, and adequate assessment, discharge in most of those instances at 6%. Cases that I'll go through with you real quick. This 13-year-old male who with nausea, vomiting, and abdominal pain and was evaluated by a physician's assistant. He was treated with IV fluids, gastroenteritis, and returned 48 hours later with acute abdomen, ruptured appendix. Was a physician at that point in time. Surgical exploration, antibiotics, was on a long recuperation. And what we saw was that the physician in this particular case, who made the correct diagnosis, called the PA to let him know that the evaluation is inadequate. The PA in this particular case, what he tried to do was to go in to elaborate. But any time that you've got a situation like that where you're rating and making it look like there was trying to reflect that there were no peritoneal signs, normal CBC, and the situation where it went right to settlement. This case ended up settling for $425,000. The thing is that you see the physicians, the corporation actually of the physicians was involved, $100,000 in this settlement. But there are some things that fall outside of the normal category, particularly with this PA with questionable skills. But there's that to be processes in place for those cases that present to a PA where the severity or potential severity of the issue be that outlet. There should be that valve to get to a physician to refer that. And so PA who's out there operating on their own, that lack of supervision is an issue for us. Again, what we get comparison of the backing, asking the question, would this have been different if a physician had been the one who was in charge of the care? Failure to diagnose issues keep coming up. Evaluation and treatment of acutely ill or injured patients should not be delegated to physician extenders. That's one of the issues that we have to make sure are in place. When you get physicians to be comfortable to refer a patient up a physician when they're acutely ill, acutely injured, or when there's a suspicion that this is something that could turn into something worse. We so often, where that Monday morning quarterback, you look and say, wow, all of the signs were there, as we saw in this last case, where if those symptoms that were documented by the PA the first time were seen by a physician, it would have been likely noted as something other than gastroenteritis. So we see an old male with GERD and Barrett's esophagus in a GI clinic by a physician's assistant over the course of 5 years. So we're talking a significant amount of time where this physician's assistant is seeing the patient. And the patient can have ongoing chest pain because of the PA kept following down that same diagnostic previously held on to diagnosis, multiple different PPIs. So the gastroenterologist sees the patient after taking a history, refers to the primary care provider, and in looking at it, not looking at the history and going by the history, what we see is that this is some other than gastro. What they scheduled this patient for a stress test, but before they could get to the stress test, patient died. So in particular cases where you've got a physician's assistant who has seen a patient over and over and over again, and we don't have that intervening time where the physician who steps in and says, okay, you've got a patient who's being seen on a routine basis every 6 months, the physician needs to see the patient. We don't have that of a physician reviewing records. That particular situation, having a separate set of eyes would have been one that would have been caught. And the female falls and injured her wrist and presents to an urgent care clinic. X-ray is read as normal, and the patient is splinted. This happens so often in the rural setting. Patients, for subsequent visits, and the X-ray report somehow or another slides through the cracks, and what that report showed was that there actually was a fracture. So, had a very poor outcome after several visits, and they're seen by a hand specialist. They see that there was a situation with a fracture involved. We only see issues related to, and this isn't just for physician extenders, but in the rural setting where you've got physicians that are reading X-rays, we see these develop into patient injury claims. So some sort of overread process in site where a physician, the extender films, and ones that make the hair on the back of the physician's extender neck stand up. I mean, if there's question, then it's something should be referred to the physician. And referring that even farther up the chain, a certain percentage of those hopefully are read by radiologists to make sure that they're addressing some of these potential fractures or potential issues, especially in more rural settings. So some focus to avoid claims or issues related to physician extenders, coming to that delay or failure to diagnose, the lack of requisite skills in a physician extender, inadequate protocols that are in place, the lack of supervision. Everyone's busy, and when you get a physician who is working his or her own schedule, you get sometimes multiple physicians that are working their own schedule, it's easy for the supervision aspect of this model to fall by the wayside. The problem is that when we end up with a claim, it can be separated by showing that there was very minimal supervision, or in some instances we've seen claims where there was a paper signed and that's all it was. And then that delay or failure to diagnose, misinterpretation of information from the patient. We've got to focus on that process with physician centers and stressing and impressing upon them how important it is to make sure that they're working up through that diagnostic process the way that they should be. The focus is failure to refer or consult, making sure that physicians, assistants, or nurse practitioners are comfortable and know that they have an outlet to get out of their comfort zone. We have situations where a PE didn't even recognize that they were in a bad situation, but in most it's a scenario where they knew or should have known. In most instances, had a pretty good idea that they were bordering on the extent skills of their abilities or of their comfort zone. Examination, again, very difficult. So work through the diagnostic process when we get the information from the patients, and then we end up with the examination of the patient. Some avoid claims and issues with physicians' assistants or physicians' extenders. Practice issues. Clearly define the scope of practice. Do those routinely. You know, particularly with nurse practitioners, there's no fair scope of practice in most instances, but that's you know, those can be pulled back on. You know, we can regulate that down to a comfort level, make sure that the proper scope of practice is clearly defined, and those high risk, high potential for risk patients are making their way in front of a physician, as opposed to being handled, in cases mishandled, by physician extenders. To evaluate the competency of physician extenders, those that are early in their careers or just coming out of a training scenario. In revision, we've had a couple of times communication breakdowns. Make sure that there are those boards, that there's open line of communication between doctors and physician extenders, so that in instances where there should be communication, there should be referral, there should be collaboration, that if you don't have the line of communication open, you sit down, and very difficult to explain how a communication error led to a patient injury. Suggestions for physician extender issues that we see out there: work on establishing and maintaining solid lines of communication between physicians and extenders. Routinely, the studies out there that show that physicians tend to interrupt, and it is just in the patient side of the house. It's also with the team that they work with, and it's really brought about out of how busy you are. But you make available, and I mean available, listening and paying attention to the physician extender is bringing to you, should they choose to bring forward. If you're not acutely listening, or if you're not paying attention to what a physician extender has to say, what is that not to bring you those issues the next time. So dedicating a certain amount of time to be able to foster those lines of communication is something that should be worked on as keenly as time will allow. That's diagnostic error again. Focusing on the diagnostic error and issues with diagnosis and performance improvement. I think that any type of education that physician assistants and nurse practitioners can get on diagnostic error, there's plenty of information out there. Online CME work related to diagnostic error, the area where we should be working on performance improvement, if for a reason, then the staggering percentage of claims that are directly related to the diagnostic errors. Those are the things that we can do, and we can start getting by learning about the different types of cognitive error, where the evaluation that's made in his or her mind that leads them down the wrong diagnostic path. I'll give you some examples of that in a couple of minutes, along with personal biases that we see. That second should be seen as a good thing. That is a discomfort or a lack of comfort that the centers have an outlet and how to pursue assistance and opinions. And this is where it's appropriate, making sure that we're using clinical decision tools and checklists. A lot of those, particularly in the world of diagnosis, a lot of those algorithms, a lot of those checklists are very beneficial. It's for the reason to remind practitioners to think along the lines of, have have I done my best in establishing a differential diagnosis? I explored all of the potentials out there. And some of those examples that I mentioned earlier, this is a great book on how doctors think, recognizing some cognitive bias. 6 here is a system where you're guided by a prototype. So you've got a young, healthy, athletic 30 male shows up in the emergency room, and because of that that prototype that you see, you don't have to go to the point that this could be something cardiac, as opposed to a cardiac issue, because it looks like that, presents as that prototype of a healthy 32-year-old male, allowing that representative bias to lead you down a path of canceling out the correct path that should be taken when working through a proper diagnosis. Is where a physician extender comes into assumption of a patient, saying treating a patient as an alcoholic or as a drug seeker, non-compliant patient. And I can't tell you how often we've seen the where a patient presents to the emergency department. They're a known drug seeker. They, show up ED 3 times a week, and of significant pain and ring the years, all of the same complaints that they had the last 3 times that they were in the emergency department. So, because that drug seeker compliant attribute, CT. And again, that cognitive bias leads you down the path of to a diagnosis with exploring all the options. Bias is where you care so much about a patient, you don't want to put them through a comfortable test or through an uncomfortable scenario. Type of bias that limits the breadth and depth of your diagnostic focus. Anchoring is fast to a first diagnosis, where the first thing you come up with is something that you hold to because it was the first thing that you came to, as opposed to allowing facts to present themselves as they come, to address the patient as the patient presents him or herself. You need to see that first lead diagnosis and to stay there. Something is close to that same thing, where if you see 10 people come through the door with a norovirus, with a norovirus, and the coming through with similar symptoms, it's really easy to crowd into that exact same diagnosis. Again, limiting what, without that history, the other 10 through your doors, you worked it up completely differently. So, and not that those things shouldn't be considered, but it shouldn't shut the door. Premature closure is the first logical diagnosis, and sticking to it. Then we've seen a number of cases where pre-closure it gets to a point of trade where it's absolutely no sense. In hindsight, be a physician close on a diagnosis, even though there was other information that was coming in after that diagnosis was made. So there are things that we can do to look at issues related to diagnosis, this just being one aspect of it. And there are multiple resources that are out there. This is an area of risk management and safety that is just exploding right now. And I think it's because we're at that point in time in our business where we're able to look at the and statistics and see just how big of an issue that diagnostic related error is for us. So when implementing physician extenders, making sure that you carefully screen, that you verify skills, making sure that you name tag identification, and introduction as a physician extender. So often we see scenarios where patients have years and years, and it's a doctor. They're dealing with a physician. We got to be candid. We got to be forthright about the fact the physician extender is a physician extender. And make have written current job descriptions, outlining the guidelines and the protocols and that scope of practice that we talked about earlier. It's easy for these things to be drawn up years and years and years without being addressed again, and you dock how far off of center physician extenders time gets down the road. And so making sure that we're these job descriptions, making sure that we're evaluating these protocols, guidelines, and scope of practice. Making sure that physician extenders are oriented to the staff and to the office, that their role is clearly defined, not only from a clinical standpoint, but exactly who should be referred to a physician extender, and should be referred to the physician. And then there is that training aspect that is as imperative to the staff as anyone else in there. And then informing patients, making sure that you've got that collaboration, making sure that patients understand the role of physician extender, making sure that they understand exactly how they should be used in their process of care. So it's that collaboration that we have not only between the staff physician and the physician's extenders, but also involving the patient in that. Presentation suggestions for physicians: define intervals that patients are to be seen by the MD. Again, the cases where we've got a patient who has seen a physician extender for 2.5, 3 years and has had no contact with them. At that point in time, I think that particularly if there is a close collaboration, there should be a defined interval. Prescriptions and the competency to write those prescriptions. Again, just reviewing and seeing exactly what is it that we're doing, how deep is the scope of practice, exactly what are physician extenders performing. Again, with some sort of routine review, and something that has to be done by the physician, even utilizing a practice manager. Without some sort of overview, it get way, way, way off center, and then it's very hard to explain how that's so far off of our intended path. There's some sort of chart review process in place, the care that is being rendered, whether it be randomly pulled or whether there's some sort of process in place for the acuity of patients being viewed by a physician. With patient satisfaction surveys, make sure that we're not in a position where you've got patients who are being viewed by a physician extender and are dissatisfied with the services they're getting. In some of those scenarios where nurse practitioners and physician's assistants were being sued, 80% of the time there was a physician as a defendant in those cases. And then other protocols as related to nurse practitioners and physicians assist regularly. For the advanced practice providers, limits of the skill set. I mean, we've got to make sure that they feel comfortable in doing what they're capable of doing, but they also have to make sure that they're comfortable in knowing when to say, this is outside of my limits. Respect those guidelines that are laid out and update those guidelines regularly. A lot of times as the skill set improves, as the experience improves, those guidelines are going to widen. They're going to get more varied. And involve physicians in the diagnosis and treatment of all patients that either fall in the category of acute trauma patients, problem where you're not able to get to a diagnosis, unresolved problems. That scenario with the woman who came back over and over and over with the wrist issue. There should be a process in place where if you get whatever the number is picked, 3 visits, 4 visits for the same issue, that should trigger a flag so that we get physician involvement. And then deviating from an expected course. If we get something that looks that's going that it was expected, make sure that there's that comfort factor of being able to involve the physician. And what that takes is the last bullet point down here, being able to communicate, to consult, and to collaborate. So some identify and honor the practice provider skill set. The case of the vast majority of physician extenders is phenomenal. And like I said, we are in recent years, there were very limited cases and issues that we saw with physician extenders. I think a lot of noticing that we're getting a lot of the fear factor now is because of the staff growth. that these physicians are very skilled. In situations where it's appropriate, provide immediate feedback and education, and there has to be that collaboration and that communication, those open lines. Make sure it is that communication, that impeccable ability for back and forth, and physician extenders to act beyond the protocols of their skills. We've seen scenarios where that is exactly what happened, where it wasn't the physician extender that was pushing limits, it was where the physician was actually pushing the physician extender outside of their comfort zone, outside of their skill zone. Supervision and monitoring, particularly with prescriptions over the and the review of charts on a routine, however that basis is set up. And then reviewing and keeping your protocols current, all patients, making sure that that we've got physicians involved. And then, of course, the last one, I think, goes without saying, advanced practice providers should not perform any procedures that doctors can't. Sounds silly. We've seen scenarios where that's actually occurred and led to patient injuries for practice claims. So, sorry, I went over a little bit on time. I am.
Okay, just wanted to make note, you cut off there for a second. I wanted to make a note that we did go ahead and mute lines because we were picking up a considerable amount of background noise. It was actually cutting you out. So now open. If anybody has questions for Robert, please ask your questions, because that's what we want to be here for, as a resource for you all. All phone lines are open. Does anybody have a question for Robert? Okay, Robert.
I am.
Okay. Not hearing any questions. I know you've been rather gracious and make yourself available. If people have questions, how do they best contact you?
Is via email, robert.thompson@mmicgroup.com. Anything related to this or any other questions you got, risk management and patient safety, be happy to collaborate with you.
Thank you,
one more
Rob.
time, MMIC, that what?
At mmicgroup.com.
Okay.
Good. Thank you.
You can also contact our office too, and we'll be glad to forward those to Robert on your behalf. So with that, if there are no other questions, we certainly want to thank Robert for his time this evening. I want to thank you all for attending. This does conclude our series on clinical risk mitigation in the clinical setting. This is what has been our 6th of 6 programs. And then also encourage everybody that even though this is our final program, we're going to continue to work with MIC, work on some programs, and so stay tuned. There'll be more programs coming. And all programs are within about a week to 2 weeks. After each program, we have those post lines, so you can view those at any time. Anything else you'd like to add before we call the night?
Just wanted to add that we have a number of our programs this year that just recently came online for CE credits, and hopefully we might be able to work with some of those in the next month.
Thanks, everyone. As always, appreciate it too, Robert. Thank you very much.
All right, through Sioux Falls, and let's sit down and see what